Welcome to our video. We will be presenting Tetralogy of Fallot. Tetralogy of Fallot is a congenital heart defect that consists of 4 abnormalities. This condition will cause the heart to pump oxygen-poor blood into the body. The 4 abnormalities that make up Tetralogy of Fallot are ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and overriding aorta. Before I describe each defect and how the heart and blood circulation is affected, I want to go over how the blood flows in the normal heart. Deoxygenated blood from the body returns to the heart through the right atrium. It passes through the tricuspid valve and into the right ventricle. The right ventricle then pumps the blood through the pulmonary valve into the pulmonary artery and to the lungs. This is where we get oxygen. Now, oxygenated blood returns to the heart via the pulmonary veins, into the left atrium, passes through the mitral valve, and into the left ventricle. The left ventricle pumps the oxygen-rich blood out through the aortic valve, into the aorta, and out to the body. The first defect in Tetralogy of Fallot that we're going to talk about is ventricular septal defect. The septum is the wall that separates the right and left ventricles. In this defect, you will see a hole in between the lower chambers of the heart, and this will allow for the deoxygenated blood in the right ventricle to mix with the oxygenated blood in the left ventricle. And pulmonary stenosis is a narrowing of the pulmonary valve area below the valve or the pulmonary artery. In pulmonary stenosis, the constriction causes less blood to reach the lungs, causing there to be less oxygenated blood flow. The narrowing also causes the heart to work harder because it is trying to push blood into a small opening. This leads to right ventricular hypertrophy. This happens because the right side of the heart is working extremely hard to get blood flow into the lungs through the stenotic pulmonary artery. Like any muscle of the body, the more you work it out, the larger it gets. The pushing of blood through the narrowed pulmonary ventricle results in the enlargement of the muscle in the right ventricle. Overriding aorta. With this defect, the aorta is located in between the right and left ventricles. When in the normal heart, the aorta is located at the left ventricle, where it takes oxygenated blood to the body. The location of the aorta in this defect allows for the oxygen-poor blood from the right ventricle to flow directly into aorta instead of the pulmonary artery. Now let's put it all together. In the VSD, there is no wall to keep the deoxygenated blood from the right ventricle and the oxygenated blood in the left ventricle apart from each other, so there will be a mixture of both. The severity of pulmonary stenosis will determine how much blood is allowed to flow into the lungs for oxygenation. Because the right side of the heart is being overworked from trying to push blood into the stenotic pulmonary artery, it will result in the right ventricular hypertrophy. Because there is more pressure on the right side of the heart, blood is going to flow from the right ventricle towards the left. The overriding aorta is located between the right and left ventricles, allowing oxygen-poor blood and oxygen-rich blood to flow directly into the aorta. The cause of Tetralogy of Fallot is unknown. However, there are some risk factors during pregnancy that cause higher incidence of TOF. They include maternal rubella, poor prenatal nutrition, maternal alcohol use, maternal age older than 40 years, diabetes. Also, children with Down syndrome or DiGeorge syndrome have a higher incidence of TOF.
Signs and symptoms of TOF usually will result within the first week of life. Hypoxia and cyanosis in the skin, lips, around the mouth, fingernails, and feet may develop as the aorta overriding the VSD allows for deoxygenated blood in through the aorta and out into the body. These children may also experience cyanotic episodes, where cyanosis and hypoxia suddenly and acutely becomes worse. Many parents may also describe a blue baby, while these episodes, also known as TET spells, occur. During TET spells, systemic oxygenation suddenly drops and the acute worsening of cyanosis causes the child to become very blue. Due to decreased levels of oxygenation, the child may also have dysapnea and tachypnea. These TET spells are medical emergencies and deprive oxygen from organs, such as the brain, from adequate amounts of oxygen. Thus, the child who initially becomes extremely fussy may then become unresponsive and even faint. With prolonged hypoxia, clubbing of the fingers may also develop over time and may be present during assessment. With clubbing of the fingers, the nail beds become soft and the angle in between the nail bed and fold is greater than 180 degrees, and the sides at the ends of the fingertips widen. In most cases, parents may also report poor feedings and that the child easily becomes tired. In some cases, however, a child may present with a loud and harsh audible heart murmur with or without all of the signs and symptoms described above. This audible heart murmur is due to abnormal cardiac blood flow, and again, it may be the only or first appearing sign. However, it is important to remember that diagnosis is not to be determined solely on this finding, since not all children with TOF may present with a loud and harsh heart murmur, and many children are healthy and may also have this heart murmur as well. A CBC may reveal polycythemia as the body attempts to compensate for hypoxia by producing more red blood cells. In addition, parents of some children with TOF that is less severe may report that the child squats frequently upon symptoms and feels better after doing so. In diagnosis of TOF, the physician will consider many factors. However, the diagnosis is confirmed by diagnostic tests, which will detect the 4 heart defects defining TOF. To diagnose, the physician will consider the child's presenting signs and symptoms, medical history, since TOF is more common in children with trisomy 21 or DeGeorge syndrome, and finding after a physical examination, such as those previously discussed, and or a heart murmur. However, to confirm the diagnosis, diagnostic tests such as an echocardiogram, EKG, X-ray of the chest, and a cardiac catheterization will be ordered. An echocardiogram will be a painless exam which produces sound waves to create an image of the heart and will detect all of the 4 heart defects defining TOF and will help to decide when surgery and what type of surgery is needed. An electrocardiogram is also another painless procedure which may also be done. This exam will record the electrical activity of the heart rate, rhythm, strength, and timing of the electrical signals as they pass through the heart. It may also present findings which may indicate ventricular hypertrophy. Moreover, an X-ray of the chest may also be done, which is also painless and may show an enlarged heart, fluids in the lungs, which is a sign of heart failure, and a boot-shaped heart due to severe right ventricular hypertrophy. As for cardiac MRI, it will produce a 3D image of the heart's defects. However, the MRI may require the child to be sedated and for the child to enter the chamber alone and without supervision. Thus, the procedure runs the possible risk of that the child may have a TET spell or a complication in the chamber without supervision. Lastly, a cardiac catheterization, which involves a flexible catheter that goes into a vein of an arm, groin, or neck and threaded into the heart for the injection of contrast, will allow for the visualization of blood flow and any abnormal mixing of blood that occurs in the heart on X-ray. This procedure will also allow for measuring pressure and oxygen levels inside the heart chambers and blood vessels.
After the child has been diagnosed with TOF, the immediate focus is if the child is receiving adequate oxygenation. The child's oxygen levels determine if immediate surgical intervention is required or if they are able to go home the first week of life. A child with normal oxygen levels and mild cyanosis would be able to go home. If oxygen levels are critically low after birth, a prostaglandin infusion is started. This will keep the ductus arteriosus open and provide additional pulmonary blood flow, thus increasing the child's oxygenation. A complete repair is usually done when the child is 6 months old, but a sudden decrease in oxygenation levels could prompt earlier corrective repair. Surgical correction of TOF is always necessary. Administration of oxygen is a necessity when the child's O2 levels are low. Analgesics are given not only to promote pain control, but also because of their sedation properties. They are beneficial for a patient who is having a hypercyanotic episode. Morphine is a drug of choice because of its predictability and reversibility. It helps to relax the heart muscle so it can decrease cardiac workload while increasing cardiac output. Alpha adrenergic agents improve hemodynamic status by improving myocardial contractility and increasing heart rate, which results in increased cardiac output. Beta blockers and prostaglandins are given to maintain ductal patency. Infants who cannot tolerate extensive surgery will receive a palliative shunt called the Fallot, but this is usually avoided because it may cause pulmonary artery distortion. A complete repair is more extensive but provides the patient with the best outcomes. The corrective repair of TOF includes closure of the VSD with a synthetic Dacron patch, which allows blood to flow from the left ventricle to the aorta. It also includes the enlargement of the narrow pulmonary valve and right ventricular outflow tract. This is done by resecting obstructive muscle tissue and by enlarging the outflow pathway with a patch. Some of the complications that can occur after the corrective surgery include junctional tachycardia, which is an abnormally fast rhythm that may require medication or a temporary pacemaker. Patients are at risk for slow heart rates due to the heart blocks. A leaky pulmonary valve may happen after the right ventricle pumps blood out to the pulmonary arteries, which leads to some of the blood to flow back to the right ventricle. This causes extra volume in the right ventricle, forcing the heart to work harder. This could lead to diminished function of the right ventricle. Pulmonary artery branch stenosis is the re-narrowing of the pulmonary valve. This makes the heart work harder than it should. Right ventricular aneurysms happen when the patch used to fix the VSD can cause the ventricle to weaken. These areas bulge out, causing the heart to work harder. Residual ventricular septal defects can be repaired again if they are too large or are causing problems with the function of the right ventricle. Coronary heart disease may develop when a patient is middle-aged. The knee to chest position is done when an exacerbation of symptoms occur. This position provides relief of dyspnea and improves oxygenation by reducing the volume of blood that is shunted through the overriding aorta and the VSD. And the VSD places more pressure in the left ventricle by increasing vascular resistance. Sedation of the child is done to achieve stabilization and decrease cardiac workload. Sedation of the child is done when the TET spells are too severe to be relieved by positioning interventions and when anxiety occurs because of dyspnea. This is the knee to chest position. Improvements in medicine and technology allow children born with TOF to lead productive lives as adults. The severity of patient's defects determines if the patient will need to stay on a medication regimen or limit exercise. Long-term follow-up with a cardiologist is essential to detect recurrent or new problems as early as possible. These include physical examination, electrocardiogram, an echocardiography, occasional cardiac MRI scans, exercise stress tests, and Holter evaluations. Thank you for